Warm greetings to everyone. Today, we will be delving into the topic gingival enlargement in periodontics with your presenter, Dr. Radhika, Associate Professor from the Department of Periodontics, Chettinad Dental College and Research Institute. Gingival enlargement. It is defined as increase in size of gingiva. The various reasons for increase in size of gingiva can either accumulation of products of inflammation or increase in cellular, fibrous and ground substance. Various terms used previously are gingival hyperplasia, gingival hypertrophy. Now preferred term is gingival enlargement. Sequelae of gingival overgrowth causes aesthetic changes, difficulty in maintaining good oral hygiene, clinical symptoms such as pain, speech disturbance, abnormal tooth movement, dental occlusion problems, enhanced risk of caries and periodontitis, mentioned by Brunel et al. In 1996. Classification. According to etiology, gingival enlargement can be classified inflammatory enlargement, drug-induced gingival enlargement, enlargement associated with systemic disease and condition, neoplastic enlargement, and false enlargement. Based on the location, gingival enlargement can be subclassified into marginal, which is confined to marginal gingiva, papillary, which is confined to interdental papilla, diffuse, which involves a marginal attached and interdental papilla, discrete, and isolated sessile or pedunculated tumor-like enlargement is seen. Based on distribution, it can be either localized or generalized. Localized is mentioned when it is limited to the gingiva adjacent to a single or group of teeth, whereas generalized when it involves gingiva throughout the mouth. Inflammatory gingival enlargement are two types, acute and chronic. Under chronic inflammatory enlargement, the etiology is prolonged exposure to dental plaque. Factors that favor plaque accumulation and retention include poor oral hygiene, by irritation of anatomical abnormalities, or improper restorative and orthodontic appliances. The clinical feature of inflammatory gingival enlargement, it originates as a slight ballooning of the interdental papilla or the marginal gingiva, produces a light crucible-shaped bulge around the involved tooth, occasionally occurs as a diffuse sessile or pedunculated mass resembling a tuber. Painful ulceration sometimes occur in the fold between the mass and the adjacent gingiva. Gingival changes associated with mouth breathing. Gingiva appears red and edematous with a diffuse surface shininess of exposed area, commonly seen in maxillary anterior region. A demarcation between exposed and unexposed normal gingiva is represented in this diagram. Acute inflammatory enlargement. Under that, first is a gingival abscess. The etiology, acute inflammatory gingival enlargement results from bacteria carried deep into the tissue when foreign substance such as a toothbrush bristle, a piece of apple core, or a lobster shell fragment is forcefully embedded into the gingiva. Lesion is confined to gingiva. Clinical picture shows localized, painful, rapidly expanding lesion, usually of sudden onset. In its early stage, appears as a red swelling with a smooth shiny surface. Within 24 to 48 hours, fluctuant and pointed with a surface orifice from which a purulent exudate may be expressed. Periodontal or lateral abscess. The etiology. The marginal closure of the periodontal pocket may lead to an extension of infection into the surrounding periodontal tissue due to pressure of separation inside the closed pocket. The clinical picture shows a localized purulent inflammation in the periodontal tissue, also known as lateral or parietal abscess. Second type of gingival enlargement is a drug-induced gingival enlargement. Drugs associated with this type of gingival enlargement are anticonvulsants, calcium channel blockers, and your immunosuppressants. Enlargement characteristically appears to project from beneath the gingival margin, from which it is separated by a linear groove. Enlargement is usually generalized in nature. Sometimes it can become inflammatory when it's secondly inflamed with the plaque. The drug-induced gingival enlargement may occur in a mouth with little or no plaque or may are also seen in a mouth with the absence of abundant deposit. Enlargement is chronic, slowly increase in size, and surgically remove it may reoccur. Pathogenesis of drug-induced gingival enlargement due to increased collagen synthesis, decreased collagen degradation, or combination of both. Third one is the idiopathic gingival enlargement. The etiology cause is unknown and thus the condition is designated as idiopathic. A study of several families found the mode of inheritance to be autosomal recessive in some cases and autosomal dominant in others. Clinical picture shows affect the attached gingiva as well as the gingival margin and interdental papilla. Severe cases, the teeth are almost completely covered and enlargement projects into the oral vestibule. The jaw appears distorted and because of the bulbous enlargement of the gingiva. Fourth one is the enlargement associated with systemic disease. These diseases and conditions can affect the periodontium by two different mechanisms. First one, either by magnification of an existing inflammation initiated by dental plaque or manifestation of systemic disease independently of the inflammatory status of the gingiva. Condition enlargement. Condition enlargement occurs when the systemic condition of the patient exaggerates or distorts the usual gingival response to the dental plaque. First one is enlargement in pregnancy. Pregnancy gingival enlargement may be marginal and generalized, may occur as a single or multiple tumor-like mass. During pregnancy, there is an increase in level of both progesterone and estrogen, which by the end of third trimester reach level 10 to 30 times the level during the menstrual cycle, respectively. These hormonal changes induce changes in vascular permeability, leading to gingival edema and increased inflammatory response to dental plaque. The subgingival microbiota may also undergo changes, including an increase in Prevotella intermedia, mentioned by Corman et al. In 1980. Marginal gingival enlargement. Marginal gingival enlargement during pregnancy results from the aggravation of previous inflammation. The incidence reported as 10 to 70%. Tumor-like gingival enlargement. The reported incidence is 1.8 to 5%. Appears as a discrete mushroom-like flat and spherical mass that protrudes from the gingival margin or more often from the interproximal space and attached by a sessile peduncle base. Another condition gingival enlargement is enlargement seen in puberty. Enlargement of the gingiva is sometimes seen during puberty and occurs in both male and female adolescents and appear in the area of plaque accumulation. It is marginal and interdental, characterized with prominent bulbous interproximal papillae. After puberty, the enlargement undergoes spontaneous reduction but does not disappear completely until plaque and calculus are removed. Under histopathology, the microscopic appearance of gingival enlargement in puberty is chronic inflammation with prominent edema and associated degenerative changes. Third one is enlargement with vitamin C deficiency. This enlargement of gingiva is generally included in a classic description of scurvy. Acute vitamin C deficiency itself does not cause gingival inflammation, but it does cause hemorrhage, collagen degeneration, and edema of gingival connective tissue. Gingival enlargement in vitamin C deficiency is marginal. The gingiva is bluish red, soft, friable, and has a smooth, shiny surface. Next one is the plasma cell gingivitis. Consists of mild marginal gingival enlargement that extends to the attached gingiva. Gingiva appears red, friable, sometimes granular, and bleed easily. Usually, it does not induce loss of attachment. Rare instances marked inflammatory gingival enlargement with a predominance of plasma cells can appear. These are associated with rapidly progressive periodontitis. Plasma cell gingivitis is thought to be allergic in origin, possibly related to components of chewing gum, dentifrices, or various diet components. Next one is a non-specific condition gingival enlargement, or also known as pyogenic granuloma. Tumor-like gingival enlargement that may be conceived as an exaggerated reaction to minor trauma may develop rapidly and the size varies considerably. Reddish or bluish, sometimes lobulated and may sessile or pedunculated in nature. Bleeding from the ulcerated lesion is common, but typically it is not painful. Systemic disease causing gingival enlargement. First one is the leukemia. Appear as a diffuse enlargement of gingival mucosa and oversized extension of the margin gingiva or discrete tumor-like interproximal space. Patients with leukemia may also have a simple chronic inflammation without the involvement of leukemic cells and may present with same clinical and microscopic features seen in patients without the systemic disease. Most cases reveal features of both simple chronic inflammation and leukemic infiltrate. Second one is the granulomatosis disease. First example is a vaginous granulomatosis, rare disease characterized by acute granulomatosis necrotizing lesion of the respiratory tract, including nasal and oral defects. The initial manifestation of vaginous granulomatosis may involve the orofacial region and include oral mucosal ulceration, gingival enlargement, abnormal tooth mobility, exfoliation of the tooth, and delay wound healing. Second one is the sarcoidosis. Granulomatosis disease is unknown etiology is sarcoidosis. It starts in individual in their 20s or 30s, predominantly affects the black, can involve almost any organ, including the gingiva, in which red, smooth, painless enlargement may appear. Next category is neoplastic enlargement. It can be either benign or malignant. Under benign tumors of the gingiva, epilis is a generic term used clinically to designate all distinct tumors and tumor-like mass of gingiva. First benign tumor is fibroma. Fibroma of the gingiva arise from the gingival connective tissue or from the periodontal ligament. They are slow-growing spherical tumors that tend to be firm and nodular but may soft and vascular. Fibroma are usually pedunculated in nature. Next is the papilloma, benign proliferation of surface epithelium associated with human papilloma virus. Viral subtypes HPV-6 and HPV-11 have been found in most of the cases of oral papilloma. Appears as a solitary wart-like or cauliflower-like protuberance and may be small and discrete or broad, hard elevation with minutely irregular surface. Next is the peripheral giant cell granuloma. Giant cell lesions of gingiva arise interdentally or from the gingival margin, occur most frequently on the labial surface and may be sessile or pedunculated. Ulceration of the margin is occasionally seen. The lesions are painless, vary in size, may occur several tooth. Leukoplakia is a strictly clinical term defined by the World Health Organization as a white patch or flock that does not rub off and can't be diagnosed as any other disease. The cause of leukoplakia remains obscure, although it is associated with the use of tobacco. Other probable factors are Candida albicans, HPV-16 and HPV-18, and the trauma. Leukoplakia of the gingiva varies in appearance from grayish-white flattened, scaly lesion to a thick, irregularly shaped keratinous block. Gingival cyst appears as a localized enlargement that may involve the marginal and attached gingiva, occurs in mandibular canine and premolar area, most often on the lingual surface. Malignant tumors of gingival carcinoma. Oral cancers account for less than 3% of all malignant tumors in the body. Squamous cell carcinoma is most common malignant tumor of the gingiva. It may be exophytic, presenting as an irregular outgrowth or ulcerative, which appear as a flat erosive lesion. Last category is false enlargement. Under that, underlying osseous lesion. Enlargement of bone subjacent to the gingival area occur most often in a torrey necrosis, but it can also occur in phageal disease, fibrous dysplasia, cherubism, central giant cell granuloma. The gingival tissue can appear normal or may have unrelated inflammatory changes. Due to underlying dental tissues, during the various stages of eruption, particularly of primary dentition, the labial gingiva may show a bulbous marginal distortion caused by superimposition of the bulk of gingiva on the normal prominence of the enamel in the gingival half of the crown. This enlargement has been termed developmental enlargement and often persists until the junction epithelium has migrated from the enamel to the cemento-enamel junction. However, when such enlargement is complicated by marginal inflammation, the composite picture of gives the impression of extensive gingival enlargement. This pictorial chart shows the treatment plan of gingival enlargement. The patients who have inflammatory enlargement, periodontal or gingival abscess, or it can be a chronic inflammatory enlargement. First, it should be, when it's a case of abscess, establish the drainage and gently debride. Recall the patient for next day and evaluate further therapy when acute asymptomatic Resolve. When it's a chronic inflammatory enlargement, emphasize block control, eliminate the irritants, consult physician if leukemia or vitamin C deficiency is suspected. Later, you can proceed with a gingivectomy or flap surgery. When it's a fibrotic type of gingival enlargement, when it's a case of drug-induced gingival enlargement, physician consultation is important. Eliminate the irritant, substitute with another drug, and later proceed with gingivectomy or flap surgery. When it's a hereditary gingival fibromatosis, it can be proceeded with gingivectomy or flap surgery after the biopsy report. When it's a neoplasm type, after the biopsy, refer for the treatment. Thank you for listening.